Good morning and welcome to the May issue of the ISGyP Live Journal Club. Today's topic is Therapeutic and Diagnostic Biomarkers. I'm Deborah Smith and I'm from Brisbane in Australia, and I'm joined by my co-moderators, Doctors Sorsaya Manua, Yeo Yen Ching from Singapore, and Rohan Lourie, also from here in Brisbane. So we've got a range of topics that we go through during the year for the ISGyP Journal Club. Today's Therapeutic and Diagnostic Biomarkers, and next month the West team is doing AI and informatics. So that's going to be very interesting, given the amount of emerging literature in that field. You can see from the timetable here that through the year we try and rotate through each of the areas of the gynecologic tract. Now, we do have two different sites. We've got the West, which issues their broadcast on the third Wednesday of the month, and we do it on the third Thursday of the month at 10 a.m. Singapore time. The idea behind this is it provides both participants and moderators a chance to work in their own time zone. So obviously when the West is doing their presentation, it's the middle of the night here. That means if you want to participate, you should be able to find something that works for you for the time that you have available. We do really encourage participation. So this is for trainees and early career pathologists. And there's two different areas within ISGyP Live that you can be involved. You can be involved in the journal clubs, which is what we're doing today, and also the interesting case presentation. We do offer mentorship ahead of events, so that helps you with understanding the literature, also the presentation, putting it together. And so I've got the addresses down the bottom. I think I'll just move. I don't know if I can get this out of my screen here. The emails down the bottom here show you who you can contact if you want to get on the list for being involved with this. The other thing is that we're also currently recruiting moderators. So if you're interested in, if you're a late career pathologist interested in gynepathology and you'd like to be involved as a moderator, go to the ISGyP website where you can see the details and put your application in, because we'd really appreciate having more people involved. And also we're looking to get people involved from across the world, so all different areas. And yes, so the learning objectives for the Journal Club is to help trainees engage with the literature and critically evaluate. It's not just sort of reading it and accepting it at face value, but looking into it in a little bit more depth. It also offers an opportunity for trainees to present on a world stage. And it also gives us a chance for us and trainees to meet each other, which is also a really nice element of it, both for the trainees and also for us as mentors. The other things that are going on this month are the interesting case presentation, which I've already just mentioned, which again is trainees and early career pathologists. And the topics for this month are seen here on the slide. We also have the podcast, which is about assessment of HER2 status in endometrial carcinoma by Natali Buza, and the slide session by Dr. Richard Wong regarding an approach to mucinous lesions of the endometrium. For each of these, you can register at the ISGyP website. Now, this is free for everyone, and if you can't make it to the live webinar, you can actually look at the recording for the week following. If you are a member of ISGyP, then you can actually go back into the archives, which are on the website, and look at all of these sessions that have been held for the last several years. So it's well worth being a member because it forms a really good resource, both for trainees and for working pathologists. This is a webinar format, and I will remind you that it is being recorded. So just bear that in mind if you interact with our participants. We do ask that if you have questions for the presenters that you use the Q&A function, and they will be then read by the moderators. And if you would like to just say hello and let us know that you're there, which we also encourage, please use the chat function. So first up is Dr. Bassel Zein Sabatto, from Cleveland in the US, who is presenting P53 immunohistochemistry in endometrial carcinoma, the clinical and molecular correlates from the PORTEC-3 trial. So Bassel, I'll get you to screen share now.
Perfect. Thank you, Dr. Smith, for the introduction. My name is Bassel Zein Sabatto. I'm a first-year pathology resident at the Cleveland Clinic, and today I will be presenting this article titled P53 Immunohistochemistry in Endometrial Cancer, Clinical and Molecular Correlates in the PORTEC-3 trial, authored by Vermij et al. And published in Modern Pathology in October 2022. So as we all know, the WHO classification in its latest edition, they endorsed a new molecular classification algorithm for endometrial cancers, which is independent from histologic subtypes. And this follows a simple stepwise algorithm that starts with assessing the POL-E status for the POL-E mutation hyper or ultra mutated subgroup. Then we assess for mismatch repair status to identify MMR deficient cases. And for the POL-E wild type MMR proficient cases, we then assess for P53 status to differentiate the no specific molecular pattern or profile subgroup in the P53 wild type from the P53 mutant subgroup. So now it's of paramount importance to correctly interpret P53 IHC, which is the most commonly used method for testing for P53 when we are trying to identify this subgroup of P53 abnormal cases, because this subgroup actually has the worst prognosis of all subgroups, and it is the most likely subgroup to benefit from the addition of chemotherapy to radiotherapy in the adjuvant setting. Additionally, some biomarkers with targeted therapies like HRD and HER2 are highly, if not exclusively, associated with subgroup. For these reasons, it's important to correctly interpret P53 IHC. And the aim of this study was to comprehensively investigate abnormal P53 immunohistochemistry patterns and their relation to clinical pathological and molecular features, and also to evaluate the concordance between P53 IHC and TP53 sequencing in a large series of hysterectomy-derived endometrial cancer samples. Now, for patient selection, they had 424 consenting patients that were originally included in the international PORTIC-3 clinical trial. The pathological inclusion criteria for the trial were included cases of FIGO stage 1A, grade 3 endometrioid carcinomas with lymphovascular invasion, stage 1B, grade 3 endometrioid carcinomas, stage 2 to 3C endometrioid carcinomas of any grade, or non-endometrioid carcinomas with stages 1A with invasion, 1B to 3C. Now, all uterine sarcomas and carcinosarcomas were excluded from participation in the trial. Immunostaining was done for P53 originally for the trial, and it was initially scored by 2 pathologists for the purposes of molecular classification only. Now, for the current study, they re-evaluated the IHC slides 1.5 years after, and now they were blinded to the original scores. And this time they looked for the different mutation, different staining patterns, and they also assessed for the percentage. They noted the percentage of mutant pattern staining. And they classified the cases into either wild type staining, which is nuclear staining of variable intensity, or one of 4 abnormal P53 patterns of expression, which are either the mutant overexpression, which is diffuse nuclear staining in more than 80%, or the null mutant pattern, which is complete absence of staining in tumor nuclei with a positive wild type internal control. The third pattern is the cytoplasmic pattern. And last but not least is the subclonal pattern, which is defined as any abrupt and regional abnormal expression in less than 80% of the tumor volume. For next generation sequencing, DNA was extracted by taking 3 random 0.8 millimeter tumor tissue cores, and this was not correlated with the IHC slide to target the P53 staining areas. It was just random. Samples were sequenced using the AmpliSeq Cancer Hotspot Panel version 5, which covered the TP53 gene in its entirety. And they also estimated the 5-year recurrence-free survival using Kaplan-Meier methodology. Of the 424 cases, 408 cases had successful immunostaining for P53. Around 2/3 of these cases were of endometrioid histotype, followed by serous, then clear cell carcinomas. Around 2/3 as well were high stage cases, either stage 2 or stage 3. And the vast majority of the cases were actually hysterectomy cases, hysterectomy specimens. In terms of p53 staining, around 68% of the cases were wild type, while 131 out of 408 cases, which is 32% of the cases, showed abnormal p53 expression, which was distributed across the different patterns as follows. The most common was mutant overexpression in around 68% of the cases. Null mutant pattern was seen in 12 cases, while the cytoplasmic pattern was only seen in 3 cases, 2.3%. Subclonal abnormal p53 expression was actually the second most common after mutant overexpression, and it was seen in 27 cases, or around 20% of the cases. One interesting phenomena that they highlighted here is that 17 of these 27 cases actually showed the overexpression in very focal areas comprising less than 10% of the tumor, and they show an example here. It's important to note here that for molecular classification purposes, they just followed a pre-established threshold or a cutoff of 10% or more to consider a case as a p53 abnormal molecular subgroup. But for other purposes in this study, they describe these cases with less than 10% staining. In terms of agreement between immunostaining and TP53 NGS or sequencing, 344 cases had successful both IHC and NGS. Of these 344 cases, 32 cases were discordant between immunostaining and sequencing, around 9%. And on a 2x2 table, this resulted in this gave a specificity of 94%, a sensitivity of 83%, and an overall accuracy of around 90%. Now, if we follow the recommended WHO algorithm and exclude the cases that are either poorly mutated or MMR deficient, this decreases the number of discordant cases to only 10 cases, and consequently enhances the sensitivity to 95% and the overall accuracy to 94.5%. These 10 cases, if we dissect them further, there were actually 6 cases true discrepancies, and 4 of these cases were actually erroneously interpreted. And the authors here made a great job illustrating these cases for us to learn from these pitfalls. So the top 2 cases were erroneously interpreted as wild type. However, if you pay attention to the blush fade staining of the tumor nuclei, it's only non-specific blush, and it's not actually real staining when you compare it to the background internal control. In fact, these 2 cases are actually null mutant pattern. The third case that was missed is just cytoplasmic pattern that was missed, so you have to pay attention to that. On the other hand, the 4th case actually showed overstaining of tumor nuclei and was misinterpreted as overexpression. However, if you look at the internal control, the stromal cells in the background are actually also diffusely staining, and this in fact was just an overstained slide. There was no mutation on NGS, and it was misinterpreted as overexpression, but when they repeated IHC, this was just an unequivocal wild type case. For molecular characteristics of the p53 abnormal cases, they describe the molecular characteristics in details. However, I just wanted to highlight one important point and point your attention to this subgroup here. These are the cases that show subclonal expression, whether less or more than 10%. And it's, if you notice here, the vast majority of these cases were actually either poly mutated or MMR deficient molecular subgroup classified. So these 2 subgroups are common in the subclonal p53 expression cases. They also investigated the prognostic relevance of the different IHC patterns, and they showed that there was no significant difference in 5-year recurrence rates between all the different patterns, whether overexpression, non-mutant, cytoplasmic, or subclonal. Similarly, there was no significant difference in recurrence rates between the different types of TP53 gene. Now, there's a lot to discuss in this article, but I thought I would just highlight a few important points. First, here they describe a novel finding that the subclonal abnormal p53 expression can be present in very focal small foci comprising less than 10% of the tumor. And the subclonal expression was frequently occurring in the context of Pol mutated and MMR deficient endometrial cancers. They also show that there was no significant difference in recurrence rates between the different abnormal p53 IHC patterns. And this finding supports the practice of combining all these abnormal patterns under one umbrella, one diagnostic entity, the p53 abnormal endometrial cancers. Currently, it's not completely understood or not. We don't know which method to prefer for p53 testing, whether to use immunohistochemistry or NGS. This study, they support the previous evidence of high agreement between sequencing and immunostaining, and they show an overall accuracy of 90%, which can be enhanced up to 94.5% when following the WHO recommended algorithm, meaning after excluding the poly-mutated MMR deficient cases. However, we all know that IHC is more widely available, it's less expensive, it's relatively easier to interpret, and allows for a quicker turnaround time than sequencing. So although they can probably be used interchangeably, there is sufficient argument to favor the use of immunostaining to assign the p53 abnormal status. Now, there's one caveat in this article that the authors actually acknowledged as well, which is the results here were obtained in a research setting. So they did the staining in batches following one protocol in one lab, which does not reflect the real world and potentially impacts generalizability. Additionally, the interpretation was performed by experts, and it's been shown that experts usually have a higher inter-observer agreement when compared to less experienced pathologists. However, even experts are subject to pitfalls and misinterpretations, and I think it's one strong point here that they actually showed us these 4 discordant cases for us to learn the pitfalls. So it was a good educational point. So few take-home points from this article. Although p53 is a robust biomarker, it is a difficult stain to perform and to interpret. And for this reason, it is important to have optimal pre-processing and optimal tissue fixation for proper staining. It is also important to have quality assured p53 immunostaining procedure. You should always keep an eye on the internal controls and make sure it's working appropriately before the interpretation. It is also highly recommended to have good external controls on the slide. We can always use NGS when we have ambiguous p53 expression. And last but not least, the most important take-home point, at least for me from this article, was to increase awareness and to be better acquainted with all the different abnormal p53 IHC patterns when molecularly classifying endometrial cancers to provide the best prognostic and therapeutic value for our patients.
Excellent. Thank you very much, Bassel. That's a really good summary of a very complex paper. So, Bassel, just so you know, there's a question in the chat there that you might want to read and think about for when we come to the end of question time. And next, I'm going to introduce Dr. Audrey Choy, who's a second-year registrar in Victoria, in Australia here, who's giving a presentation on the paper Homologous Recombination Deficiency, testing on cell-free tumor DNA from peritoneal fluid for molecular cancer. Thank you, Audrey.
Thank you for that introduction. Oh, sorry. I'll just share
I'll stop sharing. Yeah.
Thanks. Okay. So thanks again for this opportunity to present here. So today I'm going to be discussing this paper published by Rousel-Simonin and colleagues in November 2023 in the Molecular Cancer Journal, and it's titled Homologous Recombination Deficiency, or HRD testing, on cell-free tumor DNA from peritoneal fluid. So I'm just going to provide a little bit of background and context for the paper before I dive right in and analyze it. And then I'll talk about some strengths and some areas for improvement for the paper and some clinical applications as well. So just a little bit of background. I just wanted to define what is homologous recombination deficiency and also what is cell-free tumor DNA. So homologous recombination deficiency is essentially a deficiency in one of the pathways that repairs DNA when it gets damaged. So for example, in a normal cell, there are usually two main repair pathways when a cell undergoes damage to their DNA. The first one, which I'll call pathway A, is called the homologous recombination repair pathway. And the second pathway, which I'll call pathway B, is called the base excision repair pathway. And this pathway involves this protein called PARP, also known as poly-ADP ribose polymerase. And so what happens is, in a normal cell, if, for example, one of the pathways becomes dysfunctional for whatever reason, so for example, pathway B, the other pathway will compensate and the cell will continue to survive. And so why is this important in ovarian cancer? So in patients with high-grade ovarian cancer, up to 50% of the patients will have a deficiency in the homologous recombination repair pathway, in this pathway A. So these cells continue to survive because their base excision repair pathway continues to compensate for pathway A. So if these patients were given an inhibitor of this PARP protein, then both pathways would be dysfunctional and the cell will undergo cell death, which is kind of what you want for these ovarian cancer cells. And in terms of how we test for HRD currently, so it's currently only tested on formalin-fixed paraffin-embedded tumor tissue. And when it gets tested, there are two things it looks for. So the first thing is a cause of HRD, which includes genetic mutations, the most common of which that we know of is the BRCA mutation. And then the second thing it looks at is the downstream effects of HRD. So that looks at genomic scarring. And to determine this, they have a genomic instability score, which is the sum of three things. It looks at the telomeric allelic imbalance, the loss of heterozygosity, and also the large-scale state transitions. And based on the sum of these three things, you get a genomic instability score, either above 42 or less than 42. And so if you have a score above 42, that means that patient has a homologous recombination deficiency. And if it's less than 42, then they're homologous recombination proficient. So that's HRD and its relation to ovarian cancer. And then the other definition I just wanted to define was cell-free tumor DNA. So whenever a cell or a tumor undergoes tumor apoptosis, necrosis, or any active release, cell-free DNA is released into the bloodstream or the tissue. And this can be detected in the blood plasma, urine, pleural fluid, and ascites as well. All right, so that was a little bit of context. I'll just dive right into the study now. So in terms of the study design, there were two main questions that this study aimed to answer. The first one was, is cell-free tumor DNA testing from peritoneal fluid feasible, and is it clinically useful? And it looks at the quality of DNA in these samples, as well as the amount of tumoral DNA in these samples as well. And the second main question it wanted to answer was, how does cell-free tumor DNA testing compare to the tumor tissue DNA testing? And it compares the detection of pathogenic variants, as well as the turnaround time for each. So moving on to the methods, 53 patients were selected for this paper. So 19 of them were selected retrospectively in patients who had diagnosed epithelial ovarian cancer from 2017 to 2021. And 34 patients were selected prospectively from January to August 2022. And these were all selected from one centre. In terms of the sample collection, the peritoneal fluid, 15 to 20 mils, was collected into 2 tubes, which was then centrifuged twice, and then the supernatant was then frozen for testing. The DNA extraction technique, they used 2 different extraction kits to harvest the DNA, and then they used a separate assay to quality control this. And the presence of cell-free DNA was defined as a mononucleosomal spike at 160 base pairs or higher. Next generation sequencing, cancer genomic profile, was performed on both the tumor tissue and the cell-free samples, and it covered 65 genes in the retrospective patients, and then the panel was then extended to 109 genes in the prospective patients. In terms of the genomic instability testing, as I mentioned previously, currently we can only do GIS on formalin-fixed paraffin-embedded tumor tissue. So in this study, they used the MyChoice Myriad to perform the GIS. And then on the acidic fluid samples, they used a representative alternative using shallow whole genome sequencing, using this SH-HRD algorithm to give an HRD equivalent. So in terms of the results, this diagram is taken from the paper itself. So initially 60 patients were enrolled in the study. 7 of them from the prospective side were excluded when they weren't diagnosed with epithelial ovarian cancer. Of these patients, 35 of them, or 66% of them, had their procedure done at primary laparoscopy. 11 of them had it done at secondary laparoscopy or debulking surgery. And 7 patients had paracentesis for symptomatic relief alone, so relapsing disease. The mean age was 65 years old, and 98% of the patients were FIGO stage 3 or 4 at time of diagnosis. 7 of the patients did not have visible ascites at the time of diagnosis. So instead, they had indirect ascites sampled instead, which is peritoneal washings. So looking at the cell-free DNA samples, so cell-free DNA was detected in 92.5% of the samples. And as I mentioned before, a mononucleosomal spike of 160 base pairs or higher was considered good quality DNA. And as you can see here, the mean mononucleosomal spike is at 177 base pairs, with a secondary spike here at 360, and then a third spike at 520. So this just shows you that the quality of DNA from these samples was high. Not only that, but the yield of DNA was also high. So you can see that in the median concentration of total cell-free DNA. So in the direct ascites samples, the median concentration of DNA was 3,700 nanograms per mil. And in the indirect ascites samples, the median concentration was 1,310 nanograms per mil. And just to compare for you, Theory and colleagues in 2016 looked at the cell-free DNA concentration in plasma and found that that ranged from 5 to 1,500 nanograms per mil. So basically, compared to plasma, cell-free DNA concentrations are much higher in acidic fluid. And then in terms of detection of pathogenic variants, so pathogenic variants were detected in 96% of the samples, which means that when cell-free DNA was detected, it was almost invariably tumoral DNA. And the most common mutation that was found was the TP53 pathogenic variant, which was found in 86% of the samples. So moving on to comparing the cell-free tumour DNA samples and the tumour tissue samples. So I've just created this little summary table to compare the two. But in terms of detection of pathogenic variants, it was quite comparable between the two. So pathogenic variants were found in 88% of the acidic fluid samples compared to 90% in the tumour tissue samples. Interestingly, the 5 samples that failed tumour tissue testing, so in their matching acidic fluid samples, they were able to find a TP53 mutation in all 5 of them, and one of them they even found a BRCA mutation as well. So this could potentially suggest, some salvage therapy in the failed tumour tissue testing. In terms of the median turnaround time for next generation sequencing, it was much faster in the cell-free tumour samples of 21 days compared to 45 days of the tumour tissue testing. And looking at the genomic instability testing, as I mentioned before, MyChoice Myriad was used. So 44 patients underwent this genomic instability scoring. And of these, 33 of the patients, or 75% of them, yielded contributive results. Of these 75% of patients, 50% of them had a GIS above 42, meaning that they were homologous recombination deficient. And then looking at the cell-free samples, so 18 patients underwent the shallow whole genome sequencing testing. All of these patients actually had direct ascites taken. And of these 18 patients, all of them had feasible results. So of these 18 patients, 56% of them demonstrated high genomic instability consistent with HRD. And then this table is taken from the paper itself, and it evaluates the sensitivity, specificity, and concordance in terms of detection of the TP53 pathogenic variant when looking at cell-free samples compared to tumour tissue. And they found that it was 97% sensitive, 83% specific, and 95% concordant. So in terms of the discussion, I just wanted to go back and answer the questions that was asked in the AIMS section earlier. So the first question was, is testing of cell-free tumor DNA from peritoneal fluid feasible and clinically useful? And I think from this paper, the simple answer is yes. So they showed that there was high quality DNA in these cell-free samples, and there was a high concentration of tumoral cells as well. Not only that, but they found that just very small amounts, like less than 20 mils, was enough to detect this. In terms of the second question, which was how does cell-free tumor DNA testing compare with the tumor tissue DNA testing? So looking at the three different things, in terms of detection of pathogenic variants, it was comparable, as we mentioned, 88% versus 90%. And in the acidic fluid samples, they were able to find some pathogenic variants that tumor tissue missed. And in terms of genomic instability testing, so the tumor tissue had a 25% failure rate, whereas the shallow whole genome sequencing testing had 100% feasible results on their samples. And in terms of the turnaround time, as we saw earlier, it was much faster in the cell-free samples compared to the tumor tissue samples. And again, all of this is consistent with the recent research that's being published, which is showing that HRD is definitely accessible in cell-free samples, and it also correlates strongly with the tumor tissue analysis as well. And as I mentioned previously, it's been shown that acidic fluid has a much higher concentration of cell-free DNA than plasma does. So moving on to the strengths and some areas for improvement of the paper. So in terms of strengths, for a relatively initial study, this paper had a good sample size of 53 patients. Not only that, but it was able to compare the ascites and the tumor tissue taken at the same time for each patient. So that's quite good for the analysis and interpretation of results. Looking at some areas for improvement, I guess the first point is more in relation to real life. Even though the majority of high-grade ovarian cancer patients do present with ascites, there are a proportion of patients that don't. And for these patients, peritoneal washings or indirect ascites might need to be used instead. In this study, they did look at a very small proportion of these patients. They looked at 7 of them. And interestingly, they did find that 43% of these patients did yield cell-free tumor DNA. So I think this is a great start, but definitely further studies with larger groups of these patients will be beneficial when interpreting these results. And the second point, I guess, is just something to keep in mind when interpreting these results. But if I take you back to the table before, so 44 of the patients underwent genomic instability testing, and only 18 patients underwent the shallow whole genome sequencing testing, despite every patient having a matching ascites and tumor tissue sample. And it's just not quite clear in the paper where the 26 patients went. Like, it wasn't explained why they were excluded from this testing. So I think that's just something to keep in mind when interpreting this 100% result here. And in terms of the applications from this paper, so I think this paper has shown that cell-free tumor DNA testing is definitely a useful adjunct with tumor tissue testing. In real life, up to 20% of formalin-fixed paraffin-embedded tumor tissue samples can yield non-contributive results, and that can be due to sampling bias. So in these cases, cell-free tumor DNA testing from acidic fluid might be able to find some pathogenic variants that the tumor tissue would have missed. Secondly, as we've seen in this paper, it's a much faster median turnaround time. So potentially if, the patient is found to be HRD deficient, then a PARP inhibitor therapy might be able to be started earlier. And finally, this study is obviously a primer for larger studies to take place. So potentially some temporal studies tracking clonal mutational changes in patients who had previous PARP inhibitor therapy or neoadjuvant therapy. And this can maybe be used with the CA-125 to monitor progression of disease. And given GIS testing is currently only done on formalin-fixed paraffin-embedded samples, potentially in the future, if you could get more peritoneal fluid to spin it down to a cell block, some of these might be able to undergo GIS testing. And if you do have enough cells or enough tumor tissue, you might be able to look at tumor mutational burden as well. And finally, larger cohorts with a broader range of ovarian cancer subtypes can be studied, and we can see if the results do correlate with the larger studies as well. So overall, this paper has shown that cell-free tumor DNA testing is feasible, and it's clinically useful in terms of peritoneal fluid. and the results correlate well with the tumor tissue analysis. So potentially it could be a useful adjunct with the tumor tissue analysis as well. And here are my references. Thank you.
Thank you very much, Audrey. Another really great presentation on what is, again, another complex area. And lastly, we have Dr. Dr. Alexandra Walton, who is a junior consultant in Brisbane here in Australia, who's presenting on HER2 status assessment in endometrial serous carcinoma, comparative analysis of 2 proposed testing and interpretation algorithms. Thank you, Alexandra.
Okay, thank you. Yeah, so the article I'm presenting, as Deb said, looks at HER2 in endometrial serous carcinomas, and it's comparing 2 different interpretation algorithms, and it's from Drs. Hashem, Zari, and Fadari, published in the International Journal of Gynecological Pathology in 2023. So just a bit of background context for it. So endometrial serous carcinomas have a worse prognosis compared to their endometrioid counterparts. And HER2 has been identified as one of the number of actually recurrent molecular alterations in these carcinomas. And the HER2 has both prognostic and treatment applications. So from the prognostic side, HER2 positive endometrial serous carcinomas have worse outcomes compared to the HER2 negative. But having that HER2 positivity does create the option for targeted therapies, for which the FADA clinical trials, first published in 2018 and then further data in 2020, showed that there was some improvement in things like overall survival with anti-HER2 therapies. So the issue that this paper tackles is that there's no guideline on how to assess HER2 in endometrial serous carcinoma. So the College of American Pathologists suggests using the breast cancer guideline. Some other studies have also used the gastric cancer guidelines and sort of variations on that. So this was a retrospective study of 43 patients from the University of California. Their electronic records of all endometrial serous cases for which HER2 testing, that's both IHC and FISH, had been performed from 2018 to 2022. And then they assessed these results using 2 separate guidelines. So on the left is GS1, is guideline set 1, and that is based on the CAP guideline for reporting HER2 in breast cancer. And then GS2 is similar to the gastric cancer guideline for reporting HER2, but this is actually what they used in those FADA clinical trials. So the main differences are for set 1, circumferential or complete HER2 staining on the immunohistochemistry, whereas set 2 allows for basolateral or lateral membranous staining. And then the other big point of difference, which is pretty obvious, is the complexity in the FISH interpretation. So with the HER2 FISH results, you get 2 points of information. So the first is the HER2 to chromosome 17 signal ratio, and the second is the HER2 signals on average per nucleus. So guideline set 2 is quite straightforward. You either meet the threshold for the ratio or the threshold for the number of signals per nucleus, and that gives you a positive result. Whereas in guideline set 1, they integrate the IHC result. So you can see, for example, groups 1, 2, 3, 4, groups 2, 3, and 4 are also repeated in the negative results. And that's because they have the same ratio, the same number of signals per cell, but then it's that IHC result that changes and provides the shift and classification as either positive or negative. So for their methods for the IHC, they use formalin-fixed paraffin-embedded tissue using the Ventana Benchmark Ultra with clone 4B5, and the slides are reviewed retrospectively by 2 pathologists. And the other point that they commented on with the IHC is whether there was intratumoral heterogeneity, which was defined as 2 or more degree difference in staining. So that might be within the one tumor, you might have an area that scores IHC 0, along with other areas that are 2+ or 3+, for example. And for the FISH, they actually targeted the areas where they did the FISH testing to where there was the most HER2 protein expression on the IHC. And the signals are counted by 2 technologists on at least 20 tumor cells, nuclei, and then eventually final results reviewed, finalized by a gynae pathologist. And importantly, both of these methods were validated for breast cancer, and neither was specific for endometrial serous. From the stats side, they use the R statistical programming language. And then for associations between the clinicopath parameters, they were assessed with a two-tailed fissure with a p-value of less than 0.05. So for their results, unsurprisingly, they had quite a number of cases that were advanced stage. But interestingly, most of their tissue they used was from the biopsy or curettage as opposed to hysterectomy. And this probably reflects their local practice and methods, showing that most of their cases received the HER2 testing up front on the initial diagnostic specimen. And then here we've got the HER2 results. So the top half is guideline set 1 and the bottom half of the table is guideline set 2. And this first column is the IHC. And I think the thing that really stood out was the 2+ category. So for guideline set 1, they had 16 cases, and set 2, they had 23. But ultimately, this translated to similar results for their FISH positive rate. So 13 for set 1 and then 14 for set 2. So there was one case that was discordant. So the discordant case had an IHC score of 2+ by both algorithms. And the HER2 to chromosome 17 ratio was 3. So following guideline set 2, ratio 2 or more, simple, it's positive. For guideline set 1, following 3, we've got that ratio of 3. So we're in that group 2 category. And the HER2 signal cells less than 3.4, so less than 4, which means that we have to fall back on the IHC result. And given it was a 2+, that's how it ended up being negative. So the discordance between the IHC and FISH was just this one case, which worked out to be 2% of the study. Other studies had a much higher rate of discordance. Previous studies that also used that breast cancer guideline from the CAP, 11% and 25%. So this study attributed, their small rate of discordance to having a smaller cohort size, or perhaps it was due to their optimizing their FISH testing to the areas of highest IHC expression. And I think this was quite crucial in their methods, as another study by Vermij and colleagues also had cases, in their study, they had cases that were IHC 3+, but were FISH negative. And maybe this also reflects the heterogeneity that's known to occur in the endometrial serous carcinomas. Another point that they pulled out is sort of the more generous criteria of guideline set 2, really allowing for that lateral or basolateral membrane staining rather than having complete membranous staining sort of captures a few more cases. And this might be more applicable to the pattern of reactivity that's seen in endometrial serous carcinomas. And there's more opportunity, therefore, for patients to receive further treatments if you're sort of capturing more in that IHC 2+ that could potentially go on to be positive. And it also leads you to think this might be a good guideline for a stepwise approach to testing. So it's also a bit of a safety net. If you're capturing more patients in that IHC 2+ group, then if you are doing that stepwise approach where only 2+ and 3+ cases go on to FISH testing, then it's sort of almost a bit more reassuring that you're not going to miss anyone. But the downside of that is, are we going to end up over-treating people? They're going to be getting therapies that aren't providing benefit. And then there's also the risk that this might reduce the concordance between the IHC and FISH. So although that wasn't the experience in this study, other studies have had a lot more variable rates of IHC 2+. One in particular had a result as high as 90% of their cases being pushed into that category. So I think there were some points that they could have just maybe expanded upon or elaborated, particularly in the methods. So with the selection, were there any exclusion criteria? They mentioned that the cases that were included had IHC and FISH testing done. So were there any that never had that done? Were there some that it had failed due to fixation or other technical issues? And then with the testing, the fact that HER2 wasn't repeated if the patient had multiple specimens, given that most of the cases were from small biopsy specimens, could some of these be heterogeneous tumors and we just happened to capture an area that was classified as being negative? But then the flip side of that could also be argued for the hysterectomy specimens, because then you have complications like fixation. You also potentially have lower tumor percentage across the slide compared to, a good curettage specimen. And then looking at the results, how were the HER2 FISH results reviewed? So I know certainly in our center, our sort of record, particularly, 2 years down the track, our records of our FISH is based on a photograph of representative areas, and we can't actually go back to that tissue and repeat those counts and things that are initially done. And then finally, were the pathologists blinded to the results? Were these cases from their own center, potentially had they reported them themselves a few years earlier? And how many cases were actually discordant between the two pathologists? Overall, though, I think it was a really nice, simple, straightforward study design. So it was really comprehensible set of results. And I really liked how they applied strategies to optimize their testing, particularly with that FISH being targeted to the areas of the highest IHC result. And I think that really shows in their difference in their really high concordance rate compared to some previous studies. It's also a nice study because you can easily see how it could be, applied to many labs. Lots of places already do lots of HER2 testing for things like breast and gastric carcinoma. And using something like guideline set 2 might be a bit more viable for laboratories, particularly if it allows for a stepwise approach. It means you're going to reduce the number of cases that require FISH testing. I think that the next step this kind of all leads to when thinking about developing a guideline is really assessing the robustness of it. So this paper did a really good job showing the concordance between the IHC and the FISH. And then I think the next step is concordance between pathologists, sort of, super specialist gynae pathologists to more general pathologists, and the testing of the tissues on different platforms, how it's done between different laboratories. And ultimately, a study like this would also increase the sample size. Another thought was whether there's an application for an IHC only result for IHC 3+. So currently for breast cancer, that's the case in many countries in accessing treatment is just having that high IHC score. And so is IHC 3+ a reliable enough predictor in endometrial serous that similar things could happen in that case? And this would all have sort of a flow-on effect back into the sort of the economics and the workload for the laboratory as well. My final point is a bit more of a local issue in whether the IHC works with partner rather than FISH with other methods. So for example, in Australia, I know we do a lot of CISH to partner with our IHC for the HER2 testing. And so again, I think that would need a whole other series of validation to see if the concordance rate is similar. Those are my references. So thank you.
Good job. Thanks, Sally. Looks like you found a study for yourself at the back end of that talk. Look, if I'll get all of our presenters to put their videos back on. And Ellie, if you stop sharing, and we'll go through into a discussion time. So we've got about 10 minutes for questions. And I think, oops, I'll put mine on. We'll go back to that question that's in the chat for you, Bassel, first.
Yes, let me read the question from Joshua. Says, the study inclusion criteria seems oddly specific and complex. Any idea the rationale for those specific criteria? That's a good question. Thank you. There is actually a good reason for that. These are actually the criteria for the clinical trial. Because this study was built on the clinical trial. They used the same cohort. So these are the inclusion criteria for the clinical trial, which was included the high-risk endometrial cancer patients for treatment purposes for adjuvant therapy. And it was assigned either to chemoradiation therapy or radiation therapy only. So these inclusion criteria are basically the guidelines for the, or the criteria for the patients that are eligible for treatment. That's why it's like very specific.
That's true. And I think it would be interesting to know, I guess, to expand that out then to the other types of carcinoma potentially. I guess that study started being reported in 2018, so they've a lot of data still coming out from that. Okay, can I just, one of the things we talked about a wee bit when we looked at this study was about the subclonal aspect. And we talked about, you know, they had this thing where they deliberately didn't target the subclonal abnormal IHC areas for P53. What did you think about that?
Yeah, they did not explain why they just did the DNA sampling randomly, and there was they did not look at the IHC slide to target the P53 areas that it was that when it was subclonal. And it would be an interesting point for like maybe a further study to target the P53 areas maybe, and maybe have a better insight about these cases. They just said 3 random cores. They did some DNA like enrichment by micro dissection, but they did not target the P53 areas. So that would be an interesting thing to follow up on for sure.
Any questions from the other moderators for Bassel before we move? No? Okay, that's fine. Thank you. Audrey, thank you for your presentation. I did appreciate that you explained cell-free DNA as well, because it is quite a foreign topic. Look, one of the things I noticed when I read through this paper was that the methodology that they used to assess the HRD, because obviously you come to it thinking the HRD is going to be the meat of the paper because that's on the title, is actually undergoing validation. I was interested I know you kind of pulled a bit of this towards the end, but how your feelings were in terms of the paper itself and their conclusions against what they actually presented. Do you feel that was justified? Do you think their conclusion at the end is justified by the work that was presented in the paper, I guess is a question.
I think that's a good question. I also had a few, I guess, questions that popped up when I was reading the paper. I think through like some of the methodology and some of the results, like there were a few little inconsistencies that didn't quite add up, maybe with some of the flow charts and the diagrams matching the text. But I think like overall, the findings, it's such a like relatively new idea and there's not a lot of papers being published about it. But with all the other papers that are coming out, it seems to fit in the same, like the results of it show that it's a good test, it's a good way to do the cell-free tumor DNA testing. But yeah, I do agree that maybe some of the like details and the numbers just don't fully correlate with the text and some of the diagrams. But yeah, I think overall for me, the summary was like the results were okay.
I think certainly it will be quite good. We certainly get patients who are quite sick and trying to get tissue can be a problem. So it would certainly be brilliant once it's validated. Yeah, which is presumably some studies away as opposed to something that's imminent, I'm assuming.
Yeah, I think so.
Does anybody else have any experience with that? Oh, sorry. Okay.
No, I was just reading before, but I think in Australia anyway, like PARP inhibitor therapy is only, I think maybe PBS are available to patients who have a BRCA mutation. So it's not necessarily people who are HRD, like HR deficient. So I guess maybe more studies looking into this might open up this treatment for other patients as well, not just the BRCA mutated patients.
We are doing HR testing here as well.
Oh, yeah.
Yeah, and so then there is a bit of pressure to make sure we have tissue.
Yeah.
But obviously throughout the world, a lot of this depends on what your government is prepared to fund. Yen, do you have any input there from Singapore?
In Singapore, most of the healthcare sort of is private. So the thing is that like anywhere in the world, I think the stress is about getting enough tissue. And so there's always this, the oncologist will always tell the surgeon that you need to go in because we want a lot of tissue so that we have enough tissue before we start the chemo, so that we have enough tissue. But they always opted for image-guided biopsy, and sometimes they yield very little tissue, enough for making the diagnosis, but not enough for subsequent tests. So I know that there's a hospital in Singapore that always encourage, or their surgeon has moved towards, because of this HRD testing, to move towards a proper surgery to yield enough tissue so that it can provide subsequent, sort of leeway to do the testing, because so this paper is very important, because like Deborah says, tissue availability or sufficiency is always an issue. So we do the test as well.
Just a question for Audrey. Reading your paper, the patients they had came from a number of different stages along their disease. So some were biopsies prior to treatment, some were from interval debulking specimens, and others were relapses. Is that correct? Did they break that down at all? Because thinking about some of the failures we've even had on tissue testing for somatic BRCA and HRD, that sometimes chemotherapy can be problematic when you've only got a small amount of tissue. I didn't see a breakdown in their paper. Was it there and I missed it?
I did think about this as well. I initially had it as a bit of an area for improvement, where they looked at, different stages of like treatment naive versus post neoadjuvant therapy. But I also couldn't find like a breakdown of like the results, the detection of pathogenic variants in each of the groups. But they did find that they could detect pathogenic variants in patients who had neoadjuvant therapy, which I think, on tumor tissue, once you've had some neoadjuvant therapy, there's a lot of tumor necrosis or tumor infiltrating lymphocytes, which can make the tumor DNA hard to find. So I think they said that that was a positive, because they could find in the acidic fluid samples of these patients. But they didn't actually, I don't think they broke it down into, what mutations they found in each specific group.
And finally, Ali,
Yep.
full disclosure, Ali is my neighbour at work, and I'm very happy to have discovered a HER2 expert now. So what did you think about the two methods? Are you reporting HER2s?
And no, I mean, previously had experience a little bit sort of in the breast gastric side. Certainly locally, perhaps it's a reflection of working public. We don't do a lot of HER2. There's been a couple of cases that I've come across that have been requested by the oncologist, but it's not a consistent request, and there's not that consistent want from them at least to have those results to access treatment.
Well, I certainly don't report HER2s myself, and I find that breast algorithm quite complex. So when I look at those two, I'm grateful that I don't report them for a start. But also I've wondered whether the second algorithm would be easier. But on the other hand, there's so many people out there already using the breast version. Although, as you say, we do have a slightly different method here in Australia. So I'm actually, as I don't report breast either, I'm not certain what we use here.
Yeah, so like obviously the breast side, it's a bit more complicated because you have to have that integration of the results. I mean, to be honest, the actual information you're collecting from the FISH or the CISH is the same, regardless of which guideline you're using. It's more just then how you categorize it. But I think the leniency in the IHC is the difference. Breast is quite strictly, it has to be that complete membranous. Whereas the studies kind of say it's often very glandular and things, these endometrial seruses. So they do tend to have, lateral and basolateral, and they're like the gastric, they're often missing that apical side of the membrane staining. So it seems to be that pattern sort of fits better with what the endometrial serous do.
Given the findings of this study, Ali, do you think it matters which one you use? I mean, you had, was it one discordant case? I mean, could it be that we're just overcomplicating things, and can I just eyeball the slide instead and not even score it?
Yeah, there is that. I mean, this paper, I have to say, in the papers that this one referenced, this one seemed to be quite a bit of a standalone in how excellent their concordance was. So, I mean, whether that comes back to the FISH, which is sort of their perspective, is that they had the targeted FISH testing. But yeah, some other papers really did have a great discordance in their IHC. And I mean, if you are working in a situation where you're going to do the FISH testing regardless of your IHC result, then yeah, probably eyeballing it. I mean, it really only comes down to if you're getting into those nitty gritty results, where you have the overlap in your ratios versus your, actual HER2 counts per nuclei. But yeah, just this one in particular, standout, had excellent concordance. So hard to know.
I guess the devil in the detail is always going to be how it performs in the hands of those of us. It's a bit like the P53 paper from Bassel in terms of whether or not we as pathologists in a working scenario can actually replicate, can analyze these tests in a reproducible fashion. So
Yeah.
thank you, Walt. This has been a fantastic session, really informative. I've learned a lot. And we're going to stop the recording now. Rohan, that's up to you because you're host. We will stay online. So if anybody out there wants to, once the recording is stopped, you're welcome to unmute and chat. We'll chat for another couple of minutes before we say goodbye. So thank you very much for joining us.